Okay, welcome back, and thanks again for joining me for today's webinar. My name is Dr. David Kunashko. I'm the medical director at Bioflex Laser Therapy. I'm based in Toronto, Ontario, Canada. And today's topic is on laser therapy for multiple sclerosis. Over the years, I've got a lot of inquiries about whether or not laser therapy can be helpful for this condition. I myself have treated patients with MS. So I thought it would be a good webinar to have. There's not a lot of information out there. There's a little bit. I want to share that with you as well as anecdotal. And so it might be helpful in your clinical practice as well. It's a chance for you to ask questions as well about this topic. So I'm going to, if I can figure this out, I'm going to do a little bit of an overview of multiple sclerosis and talk a little bit about its etiology, epidemiology, pathophysiology, and signs and symptoms, and then a bit about its progression, prognosis, and how they currently treat MS. And then I will share some, not all of the research on photobiomodulation laser therapy and multiple sclerosis. A lot of animal model work, not tons of human clinical trials, unfortunately. And then I'll talk about how we approach treating multiple sclerosis with photobiomodulation using Bioflex equipment. And then at the end, you always have a chance to ask questions. You can type those questions in at any given time in the Q&A box. I'd really appreciate that. In the chat box, let me know where you're from, where you're listening to today, if you have our equipment. Today's session is geared more towards our Bioflex professional grade equipment, but it's kind of applicable to any type of equipment that you might have. So I want to start off with this quote, and this is from Multiple Sclerosis or MS Canada. And Canada, as probably many of you are aware, has one of the highest rates of MS in the world. And it's estimated that 90,000 Canadians are living with the disease. So on average, 12 Canadians are diagnosed with MS every day. So in Canada, at least, it's a relatively, unfortunately, common disease. And you're probably also aware that MS is a chronic autoimmune disease, and it affects essentially the central nervous system. And interestingly enough, it's only found in humans. There are no animals that have multiple sclerosis, although when we do animal model experiments, we do things that mimic inflammation, neuroinflammation, and degradation of the myelin sheath, but it's not MS. So I thought that was quite interesting to note. And it's characterized by this sort of chronic inflammation, although in later stages, the inflammation actually goes away. And it does cause destruction of myelinated axons in the central nervous system. And so it's the myelinated axons in the central nervous system that are actually the targets of multiple sclerosis. And it can cause varying amount or degrees of damage to both the myelins and the axons, and then affect a person's ability to perform motor function, muscle movement and sensory issues as well. This has come up a lot recently with some celebrities that have MS, in particular, Christina Applegate. And you may or may not be aware of her and her battle and her struggle with MS. And unfortunately, she had symptoms for several years, but didn't really, I guess, catch them or pay attention to them. And so when she was diagnosed, it was already progressed. And that's the one thing, if anything, you get out of today's lecture, is that if you're experiencing certain symptoms I'm going to talk about, get them checked out. 99% of the time is not MS. But if it is MS and it's caught early, then it can be managed much, much better than if it's caught later. Stat-wise, it affects about 2.3 million people worldwide. And typically the diagnosis is in the 20s, 30s, 40s, and 50s. That's usually where you see the diagnoses. Tends to be a little bit more female dominated than males. And again, it's hard to say why. And you probably also know that it seems to be more common in Northern European descent, like away from the equator, and sort of white skinned individuals as opposed to darker skinned individuals. I guess that has to do with the fact that location wise. The origins of MS are still really kind of vague, and there's probably lots of different issues going on. There's an interplay of a whole bunch of things that they suspect. There's nothing confirmed, whether it's genetics or food, environment, all these kinds of things. And the newer research has sort of leans towards a fusion of genetic susceptibility or vulnerability and environmental agents right from young adulthood. So it's a slow progression as a person gets older. And that might be because that younger person had a disease or an infection or trauma or other things that made them susceptible to coming down with MS. One is the fact I've talked a lot about is lack of vitamin D or not enough vitamin D. And again, that has to do with the equator thing. So the farther you away are from the equator, the less sunlight, less vitamin D, cloudy environments, that kind of thing, you tend to see more MS. Time of year that you're born apparently is all maybe a factor. Tobacco use seems to be a factor. Exposure to certain pathogens, including Epstein-Barr virus, may be a factor. But it's a deficiency in vitamin D that that this seems to be linked a lot to people or populations living at a higher latitude. And it reduces the production of what's called Th1 mediated pro-inflammatory cytokines. And if you look at sort of this map that shows that MS, like in the blue is where it's quite prevalent. And you can see here the prevalence near the equator is almost like non-existent. And then as you go farther away, you start to see greater and greater prevalence. And the cases grow about 50 cases per 100,000 living 45 degrees north or south of the equator. So that tends to be what they've found over the years. And there's some proof, research shows that individuals have an inherited susceptibility to MS. It's not like there's a gene. There's no gene that has been linked to MS. It's more susceptibility. That's why it's so kind of gray and to this day very difficult to figure out. So it's important to understand there is no gene or series of genes that trigger it. The genetic studies have shown a connection between first, second, and third degree relatives that have come down with MS. So as I mentioned earlier, it's been postulated that certain types of infections, bacterial and viral infections, may promote later development of MS in these people that are genetically susceptible. And disorders in late childhood may introduce what's referred to as foreign antigens, and these activate T helper cells. That's what Th1 cells are. And they induce the characteristic sort of autoimmune response. The way to think about this is I think everyone's familiar with rheumatoid arthritis, where it's an autoimmune disorder and the antigens of the joints are triggered as foreign to the body, to the immune system, and it causes inflammation and destruction of the synovial lining and the cartilage and so forth. That's exactly what's going on in RA, but in the case of multiple sclerosis, it's actually the neurons that are attacked, not the joints. So in that respect, it's kind of similar, although RA there is genetic or there's genes involved there. So another factor might be severe injuries that affect the brain or the spinal cord as possible triggers for MS. The trauma may be related to issues with the permeability of the blood-brain barrier, allowing these antigens to sort of get into the central nervous system and the entry of these T helper cells that trigger this autoimmune response. So the initiating factor for the inflammatory response that leads to myelin destruction and then formation of these lesions, these multiple sclerosis lesions. This latest stats show that smoking increased the risk of about 50% of developing multiple sclerosis. That's smoking. I don't know. They don't have any vaping stats. Smoking with MS have unfortunately a much worse long-term prognosis and a greater incidence of brain atrophy than non-smokers. Let's face it, anytime you smoke, hopefully none of you do, but it just makes diseases worse and more prone to diseases. So if you can quit, or that would be a good idea. MS patients are more likely than the general population to have comorbid conditions associated with worse quality of life, a higher burden of disability, and higher mortality rates. I'm going to talk a little bit about that as we progress. So as I mentioned, injuries, they may also, like, car accidents, those kinds of things, may also trigger MS. And again, I think this might be a repeat slide. The trauma seems to cause an issue in the permeability that leads to the Th1 helper cells that are triggered enter the central nervous system. So MS is one of the most prevalent neurological illnesses in the world, and in many countries, including basically Canada, it's a leading cause of non-traumatic neurological impairment in younger people. So it's really quite an issue for anyone that's been diagnosed with MS. The stats in the United States is it affects around 400,000 people. And I think I mentioned about 2.5 million people worldwide. Onset is 20 to 40 up to 50, although you tend to see it more in that 20 to 40 category. So the issue here really is these immune cells. And what happens is MS is considered autoimmune and is caused by an autoreactive immune cell that basically traverses or crosses the blood-brain barrier and then attacks. So regular deletion of autoreactive immune cells during development occurs in the thymus or bone marrow through central tolerance B cells. So what happens normally is that as you're growing up, you can have these kind of wacko Th cells, but they're taken care of and they don't create any problems, mainly through the thymus or through the bone marrow. But that's in a normal, healthy situation. So even though some of these cells can escape and be released into circulation, the tolerance is pretty high for it. And therefore, in most cases, you're not going to see development of something like an MS unless there's some kind of triggering event. In most cases, the condition was referred to as relapsing remitting with brief bouts of neurological impairment, and it tends to resolve either entirely or almost entirely before it recurs again. MS is primarily caused by this autoimmune attack. And as I mentioned earlier, it's this T1 helper cell or Th1 cell and 17 Th helper cell or Th17. This leads to central nervous system endothelium adhesion, blood-brain barrier crossing, and then an immune attack across into the central nervous system. So just to break it down, now I'll get into a little bit more specifics. There's possibly genetic factors, there's possibly environmental factors, and there's possibly infectious triggers. It might be a combination of all these. And this will lead to an activation of these, what's referred to as myelin reactive. That's because they target the myelin T helper cells, 1 in 17. Then they infiltrate the central nervous system instead of being cleared through the thymus and the regular processes in the body. And then you start to get breakdown further of the blood-brain barrier, more immune cell recruitment into the brain because there's inflammation, neuroinflammation. Then you start to get ongoing central nervous system tissue damage to the point where you start to get symptoms, right? So by the time a person experiences symptoms, this is already underway. That's why it's critical that the disease process be treated as soon as these symptoms are first noted. This main model of how it occurs is called the outside-in model of multiple sclerosis pathogenesis. And again, you can kind of look at this is a schematic. And so I don't know if you can see this kind of like tube-like structure here. That's a blood-brain barrier. And so on the outside are these Th1 and Th17 helper cells, and they are triggered by certain antigens. Again, that might be an infection or might be something that's going on in the body. And then they can cross the blood-brain barrier. And then once they enter the blood-brain barrier, they target the myelin sheath of neurons, And then this causes a reaction. Then you get white blood cells in there that cause cytokine release and further tissue damage. And then you start to get the body basically reacting to this interaction of the so-called foreign antigen, although it's really the body's antigen that is breaking down. So that's essentially what's going on. So you get myelin destruction, and then you can get to some degree repair and remyelination, but it's a progressive thing. So you can't get full repair all the time. And then over time, then the symptoms start to become more progressive. So most people with MS experience two stages of the disease. The first stage is referred to as this relapsing remitting MS or RRMS. And as I mentioned earlier, it's characterized by episodes of new or worsening symptoms. So these are relapses. And then it's interspersed with periods of partial or complete recovery. That's a remission portion. So most RRMS patients will gradually enter what's referred to as a progressive phase of the disease, although not always. And it's called secondary progressive MS or SPMS, in which symptoms continually sort of worsen over time. And even if there are no relapses, the symptoms slowly get worse. The time it takes to go from those two stages can vary substantially, and they can be heavily influenced if caught early by and treated with what's referred to as DMT or disease modifying therapies. And I'll make the argument today that photobiomodulation should be one of these disease modifying therapies. I'm not saying in replacement, I'm saying in conjunction with the medications and drugs that are already out there that have shown clinically to be effective for MS in its early stages. But if left untreated, about half RRMS patients would progress to the secondary stage within 10 years of the disease, compared to about 10% if they're treated with these disease modifying therapies. And this is over a median of 32 years. In approximately 15% of MS patients, the disease will enter a progressive phase immediately with symptoms that continually worsen, called primary progressive MS. So a small percentage, 10, 15%, right from the hop, have pretty progressive symptoms. And that's, of course, the worst prognosis. So symptom-wise, these are the things that you need to be aware of: fatigue, anxiety, low mood, decreased focus, things like constipation issues. They're all symptoms that are frequently encountered by people that have multiple sclerosis. Unfortunately, as you can kind of see, these symptoms are frequently encountered by people who do not have MS, right? So it's more than a likelihood that these symptoms may not be multiple sclerosis, right? But that just goes to show you that if you're, and we look at things like COVID, like I think I'm just getting over a case of COVID, to be honest. Although I was checked negative, I've had like extreme fatigue for a week, and there's nothing else to explain it. And but I definitely had something. I knew I had something, right? When you have a symptom and it's not going away in relatively short order, like in the weeks, that kind of thing, like get it checked out and make sure you have a full workup. And maybe if there's other things going on there as well. But it's better to rule it out than to ignore it and then, oh, it's nothing or whatever. And then years later, like in the case of Christina Applegate, she was diagnosed and it was already quite advanced. Some of the common early symptoms, as already mentioned, but some other ones include vision changes. This might be due to inflammation of the optic nerve, numbness and tingling. Okay, this is a really common symptom. Like lots of people have numbness and tingling. You wake up, your arm is numb, that kind of thing. It might be a positional thing or what have you. But this is sort of recurring, unremitting, kind of paresthesia in usually the extremities, and that should be checked out. I mentioned fatigue, other things like loss of balance, right? Dizziness, muscle pain, muscle stiffness, even spasms, tremors, bladder and bowel issues as well. So you can see that these are very generalized symptoms, and oftentimes there's only a few that MS patients will have, but when you put them all together, it could lead towards the signs of the diagnosis. Other symptoms that may be apparent are speech and swallowing difficulties, cognitive issues like issues with thinking, learning, and planning. Things like depression, anxiety. I think that kind of makes sense. Even in difficulties with sexual performance and that kind of thing may also occur with MS. So during the relapsing remitting phase, symptoms will, as I mentioned, will come and go over time. For it to be diagnosed as a flare-up, the symptoms need to last at least 24 hours and occurs at least 32 days after the previous flare-up. And the flare-up can last from weeks to months, okay? These could be followed by periods of remission where symptoms may not appear at all for months or years, and the disease doesn't really seem to be progressing. During the progressive phase, the symptoms become obviously progressively worse, and the symptoms may not experience any improvement or remission. So in other words, the paresthesia, the balance issues, these other things, they're not improving. They're just there, and they seem to be getting worse. They're not sort of going into remission. Not all people with MS will experience this progressive phase. Now, treatment-wise, they're getting much better at coming up with medications that are helpful. There's a whole host of them. I'm not going to list them, but I will talk a little bit about them. And they essentially can help control inflammation that injures the nerve fibers and can reduce the frequency and severity of the relapses and ease the MS symptoms. So it's basically what you want to do is get diagnosed early and then slow the accumulation of nerve damage. And this may reduce or prevent further disability during the course of MS, right? So basically it improves your quality of life for much longer so that your mobility isn't impaired quickly, or maybe not to the degree that it would if it was treated early. So those diagnosed with the relapsing forms of MS have likely been advised to start treatment or should start treatment as soon as possible. So the best course of action is to control the inflammation and prevent irreversible tissue damage early on. So current medication for relapsing forms of MS have been shown to work and be effective for majority of patients diagnosed with the progressive disease where inflammation plays a lesser role. Has not shown to be effective. So in other words, the treatment modifying therapies, the drugs, those are effective in inflammation. When it goes to the progressive form, it seems as inflammation changes or alters and it's not the same. And those medications they don't seem to be as helpful. I think there are some medications for the progressive form, but they're not nearly as effective. And so the types of medications, there's three main categories. There's injectables, there's orals, and then there's infusions. And I won't go into all the names. If you're interested, MS Canada, there's multiple sites that talk about these different types of medications that can be very helpful. Then there are specific medications for the symptomatic relief, whether it's depression or sexual dysfunction, all these kinds of things. Those are medications that have already been out there and used for those symptoms and will be helpful, but of course, it's not altering the pathogenesis of the multiple sclerosis. So although the disease itself is rarely fatal, it can cause many complications that basically reduce life expectancy. And the life expectancy of patients with MS is approximately 7 to 14 years shorter than that of the general population. So you can imagine if you get it treated early on, your chances of it affecting really your life expectancy isn't that great. It's not going to alter it that much, which is really good. And you want to make sure you have a good quality of life. So really, as I mentioned, the key is to treat it as soon as it can be diagnosed. The average life expectancy of a patient with MS on average is approximately 35 years from the disease onset. So, if it's diagnosed in the 40s and, into your 70s or what have you. So it's not that far from normal life expectancy. And the chance that they will still be able to walk unaided 15 years after the disease onset is about a 50-50 proposition. That's after 15 years from the initial diagnosis. Okay, let's talk a little bit about photobiomodulation or low-level laser therapy for multiple sclerosis. There's some review papers on it. This is the one I want to present. And then there's really only one human clinical trial. It's not a great one, but it's okay. There's one that it seems to be undergoing right now, but there's no results yet. And there's lots of animal model research as well. So the animal model research has shown that LLLT, which is the old term for low-level laser therapy or photobiomodulation, can reduce the inflammatory cells and mediators and inhibit inflammation, neuronal loss, and cause remyelination in the neurons. Now, remember, this is in a mouse model. So it's a little easier to get light into the central nervous system in mice and rats than in humans. So they use what's called EAE mouse model rats. And it's basically a genetic traits that they have the mice or the rats have neuroinflammation and this causes demyelination in the central nervous system. So it mimics MS. And what they found was that when these mice in these multiple research papers, when they're treated with low-level laser therapy, the inflammation reduces the Th17 and Th1 cells. Remember, those are the ones that cause the problem. They get reduced. And they found that the remyelination increases in these mouse models that are treated with LLLT. Just to look at the research from 2016 to 2020, they're showing here 6 research experiments, and if you look at the models here, they used usually red or near infrared light. That they looked at if there's one here in 2016. It shows improved the functional status of patients. I couldn't find that paper. At least I couldn't pull it up. But overall, it seemed to be helpful with certain symptoms or certain functional characteristics in MS models. So photobiomodulation, this is from the paper. What they suspect the mechanisms are is that inhibits apoptosis, which is cellular death, and it can regulate cell viability. It really does this through the mechanism that I've talked about before, which is increasing the metabolism of cells through the mitochondria. It can suppress inflammatory responses and stimulate antioxidant activity. This kind of boosts the cell. It enhances the production and release of tumor growth factor beta, brain-derived neurotrophic factor, which is important for neuronal survival and growth, platelet-derived growth factor, and glial-derived neurotrophic factor. These are all things that just help neurons survive and actually remain healthy and propagate. It's also suggested that it might stimulate neuron regeneration and induce the proliferation of Schwann cells. This is the one human trial I want to share with you. It's not the greatest because it was it was done in Poland, so there's a barrier there to the language and everything and how they collected data, but it's something. And so they looked at 22 patients with MS, and the good thing was they were diagnosed with MS through an MRI and also through disability scores, and they had the disease for quite a long time already, so over a decade. So these are patients that already have significant symptoms due to MS. They used relatively low power here, 10 milliwatts in red wavelength. Now, they didn't share where they treated, I suspect along the spinal cord, and it was a 10-minute total treatment time. So they had to treat fairly lengthy to get enough dosage. I don't know why they didn't use near infrared, but I don't know. And they treated multiple points 6 days a week for 21 days. Then there was a month break. Then they did it again, a month break, and did it again, essentially is how it worked. And what they found was that the results were in kind of three broad categories. 7 of those patients, or around 32%, didn't report any positive improvement, subjective improvement, and neurological tests didn't show anything improved either. Then another 7 patients reported subjective improvement. So they're saying, hey, I feel better, it's subjective. And that could be due to, or things like decreased numbness or paresthesia, better appetite, better movement, those kinds of things. But the neurological test didn't identify any changes either. So it's strictly subjective. And then the highest percentage, roughly 36% or 8 patients, reported both subjective improvement, and they were confirmed by neurological testing. And they had at least a reduction of disability by at least 1 point on a scale that they used. I'm not familiar with it. So basically, it's showing that it was objectively helpful in these patients. So with respect to the research, what basically the research shows is that it could be helpful to improve muscular strength, to improve motor drive improvement. So, muscle contraction, ability to ambulate and walk and balance, vitality, cognitive improvement, lower ataxia was reported, including better walking and gait patterns, better balance, those kinds of things as well. Now, let's talk a little bit about how to approach treatment of these patients. So first of all, it's really important to understand that photobiomodulation for MS is considered experimental and off-label use. We does not have evidence to clearly indicate that it's going to do anything. But I suspect it would be helpful to some degree, especially for symptoms. So, and in my experience, anecdotally, I've seen good improvement, but I'll talk about that. So over the past 30 plus years in our clinic, so we have a large clinic in Toronto, we've been treating a lot of MS patients over the years. So we've done case studies and reports and such. And of course, not everyone responds, but we have seen some good improvement. Ideally, treatment should begin as makes sense, as the symptoms appear initially, right? And the confirmative diagnosis is made. The goal of photobiomodulation is similar to using disease-modifying therapies, not a replacement, but in addition to, in which the progression and symptoms are controlled to some extent. So there's no specific protocol. I know there's some questions here, and I'll get to those for sure. So just type them into the Q&A box. So I'm not going to give you a protocol. That's not kind of how we've approached treatment. And every patient's going to present differently, different symptoms, different locations, different stages of the disease. So we don't really have that, but I can kind of guide you what I learned from Dr. Khan and then myself treating patients and just in general from the research. So number one is you want to treat along the central nervous system. So typically we recommend treating along the cervical spine, the thoracic spine, the lumbosacral spine. And that's really just to stimulate photobiomodulation, both directly and indirectly, systemically to the central nervous system. And that's just going to use the standardized protocols that you have. Level 1, stage 1 of cervical, thoracic, and lumbosacral region. Now, you don't necessarily have to do all those regions, but, if the symptoms are mostly upper limb, then definitely do the cervical spine. If it's upper limb and lower extremity symptoms, then I would do cervical and lumbosacral regions as well. And then you're going to target the areas that have symptomatic issues in those regions, right? So paresthesia, pain, muscle spasm in those appropriate regions, muscles or skin or areas, might be the hands, might be the legs, might be the feet, wherever it is, just use the anatomically specific protocols in the manual to treat those areas as well. All right. So again, you're just using the protocols in existence already, but you're trying to treat both the central nervous system. That's really critical for this. and then to treat the affected areas where those, where those nerves supply that's problematic. So if you're not familiar with, but I'm sure you are, when you look at treating the cervical spine, you want to apply the large surface array on the back of the neck, certainly at the suboccipital region and down, all the way as far as you can go. And you could treat the lateral side on either side if you wish, or just wrap it, or you can be creative. You can actually just do it two perpendicular positions as well too. As long as you treat in and around the cervical spine, then I think that will be effective. And again, you could treat the thoracic spine. I'd probably suggest this B placement as opposed to the first one. It just treats a little bit more on either side of the nerve roots and overlying the pathways, into the central nervous system. And then I would suggest you treat the lumbosacral region, if that makes sense, right from, T12, L1 down to S1 areas as well, and even into the exiting lumbosacral roots. So if the symptoms are mild, then treatment can be initiated maybe 2 or 3 times a week for about a month. So give it a good month and monitor the symptoms, see how they are making out. If they seem to be effective and helpful, which is great, and then you can maybe move to a maintenance. You might want to go from 3 times a week to twice a week to once a week, see how they're doing with that. You might also recommend that they do some home sessions as well with a personal system like a P180 or whatever it is. That's another option that might be very beneficial to these patients. Having the laser probe along the spinal cord region is really beneficial. So I really believe that having the laser portion in the clinic is going to be very effective in conjunction with the dual arrays as well. Now, if the symptoms are relapsing or severe, then you may have to do daily treatments until they calm down or under control, and then you can start to reduce frequency from there. When things are relapsing and quite severe, again, they may have difficulties coming into the clinic or don't want to come to clinic, and that's where having the home system is very helpful, and then they can come in when they can, especially for the laser probe portion of the treatment. Okay, so that is it for today. Next webinar is on post-workout muscle recovery, and I think there are some questions. I'm going to see if I can get to those. So question here from Betsy, it's usually really hard to diagnose MS. It takes years to diagnose it often. Perhaps some of the lack of MS prevalence near the equator is due to non-diagnosis. No, I don't so yeah, definitely hard to diagnose for sure. Although the imaging now is getting much better, but you need to have a certain amount of lesions to see it on the imaging. So there's certain diagnostic tests that they do. They're getting much better at diagnosing it. But no, I think it's definitely prevalent wise. It's definitely more prevalent away from the equator, not just because of lack of diagnostics there. At least that's my understanding. Here's one from Dr. Mike Sider. We had a very interesting case of a regular patient in our office who had MS for quite a few years and would experience a flare-up that would lead him to be hospitalized for a few weeks at a time. He received a bad report from his MRI 3 years ago, and his neurologist said that his condition would start to degrade much more quickly. It was around this time that I did a master's class, and the neurologist in South Africa, which is Dr. Ashley Bonjan, was talking about treating patients with MS. I suggested that we try it with this patient and gave him 20 sessions and chalked it up as researched. Long story short, he's been coming in once a week since that time and has had no flare-ups, hospitalizations, or changes in his follow-up MRIs. I mean, that's awesome anecdotes. I mean, that's the kind of thing, Mike, thanks for sharing that, because end of the day, I wish we could do nice clinical trials. The problem is that they're very expensive. They're millions of dollars, and it's very challenging to do it. So, but anecdotes are still part. I mean, even if it's low on the echelon of evidence, it's still evidence, and it goes to show you that it may be helpful. It's worth a try. There's no side effects with it, And there's no downside to trying at least for a month or so to see how they responded. I appreciate you sharing that, Mike. Let's just see if there's anything else. That's about it. So again, thanks for joining me today. Hopefully you enjoyed it and learned a little bit more, unless there's another question here. Hang on. Nope, that's it. Take care, everyone, and we'll see you next time. Bye now.